Control arm?
Control arm was Catherine, so adjuvant TDM1, 14 cycles of one, 14 cycles of the other, both given IV every 3 weeks. Very, very even.
Very even. Will you use 11 going into 5, or have a preference for one or the other?
I think that is the billion-dollar question these days. I may have a less popular opinion on that. I think, honestly,
That's the fun part.
either would be a win for patients, right? I mean, I definitely want to use one of them in the curative setting, so that's the good news. I've heard some people say, I'm really going to reserve this for patients that have residual disease, a la DB-05. Some patients are going to have a PCR. Some patients are going to do well anyway. I'm going to kind of salvage with trastuzumab deruxtecan, which I think is a valid strategy. But I was really compelled by DB-11, actually. And I thought it was really attractive that the ILD rates were really low in 11, 5%, no fatal cases.
Which is important.
Right. And then, conversely, certainly DB-05 was tolerable, et cetera, but there were some fatal cases. And the ILD was above 10%, so more along the lines of what we expect, right? So part of
increased exposure.
Exactly.
14
versus 4, right?
Yeah.
So, I think in the breast cancer world, especially in the curative setting, we don't save the best, right? I really want to get patients to a PCR. Now, maybe people with a little bit less disease or something, we could kind of get in the debate of that. But somebody that I think really has high-risk disease, I think I'm leaning a little bit towards 11. What about you?
So I think the difference here is, one, when the 5-way, you can give what is standard of care in the U.S., Taxotere, carboplatin, Perjeta, Herceptin, up front, and then DB-05 later. The issue becomes the patients who don't get past CR on DB-11, and they have a lot of disease, then I think, have to consider anthracycline for that patient.
I do, yeah.
And then possibly even TDM1 after. So you're potentially giving a lot more therapy. So I see both arguments, but there is almost, 60, 70% of patients, was it 80%? What is past CR rates on 11? Was it 67, 68%? 67%, yeah. So potentially 67%, you don't even have to worry about that. So that's the argument here. I fall with you, though. Okay. I was really impressed with the behavior of just 4-TDXD, and I will lean more towards that, but I would have to also consider maybe in the ER-positive space where you don't think they're going to get as much PCR.
That's a valid point.
That maybe we'll take the other route.